Bonjour mes amis, je vais parler de l'aspect biologique de la cicatrisation du tendon pour la coiffe des rotateurs. Désolé, I have to switch now in English because for presentation it's easier for me to present in English. Of course, discussions could be made in French, but I'm sorry, I'm not able to present everything in French. So we have to understand two major points. First, the mechanism of a tear, which you see on the upper part, and also of a repair. And then on the second part, what can I do in my daily life to affect the healing rates of repairable rotator cuff tears in understanding the tear or even after repair? And then the question is where we are here and now or where we might gonna go in the future. So first, in terms of an acute tear, there is at the beginning an inflammation and an apoptosis at the beginning, subsequent to an acute rotator cuff tear. So after this inflammatory response within the first days, there is a cellular proliferation and remodeling. So 2 points, first inflammation and then a cellular response. This cellular inflammation is mainly orchestrated by two types of macrophages. M1 macrophages are those guys which are the bulldozers who phagocyte and destroy everything at the tear insertion site and get rid of all the debris. The M2 macrophages are those which are the guys who buy the briquettes in the supermarkets and try to remodel the tissue. So the acute, positive, good inflammation on the left-hand side is orchestrated by M1 and M2s. Conversely, if you have a chronic activation, the inflammation turns towards a bad or even an ugly inflammation with a chronic activation. And this switch from the M2 to the M2As, this chronic tendinopathy or tear cellular distribution is in this situation. So the question is, where is this switch and when is this switch to a persistent memory effect of the cells? Because this might be also the switch towards then the chronic tear. And this is a busy slide that don't remember at all the points. I would like to keep you in mind just two names. First, NF-kappa B. It is a pathway, it's a cellular, intracellular nuclear factor. You see we are here in the cells, which goes towards either apoptosis, extracellular matrix disruption, or scar formation and fibrosis. And this NF-kappa B activity, if it's increased, it has a decreased effect on tearing and on the impaired healing after repair. And additionally, there is weaker bone at the insertion of the rotator cuff if this activity is increased. Upstream to this pathways, there is part one, the second thing which I would like to keep you in mind. So part one has not only an effect on NF-kappa B, but also on the fatty infiltration, on degeneration and regenerative processes. So 2 points to remember, part one and NF-kappa B, as I already mentioned. Because if we block in a knockout mice model, this NF-kappa B through part one, if part one was blocked, we have a better inflammation, less apoptosis, less scar formation, and better properties of the muscle and the tendon. And the question is when it is important that we block this NF-kappa B or this part one. And so we make an experimental study and we looked when is this switch and this blocking important switch on part one after a rotator cuff tear, 1, 3, and 7 days. And interestingly, at 3 days, there is a trend towards this downregulation and no difference at 7 days. So this switch between a good and a bad inflammation might be within 1 week after a rotator cuff tear. So that might be also one of the reasons why an early repair could be better than a late repair. Of course, we heard a lot about the critical shoulder angle and all this omometry, versus the biology, which is the chicken, which is the egg. We don't know it. And I think there is an interesting point on morphological study which needs to come up in the literature. It's not just a two-dimensional angle which explains everything, I'm pretty sure on that. If we switch then from the origin of the tear towards the tendon and bone healing, we heard about after the inflammation, we have the cellular response, which includes proliferation and remodeling. It takes weeks or months, these reparative processes. And the question is, what cells are recruited to form healing? Which cells contributes to make the healing subsequent to a rotator cuff repair? We make this Krelog study where we labeled all the cells in the different tissue, and we were able to look which cells are recruited to form afterwards this healing in a mice model. Are these the tendon cells, the cartilage cells, the paratendon cells, or the progenitor cells? And I can tell you only paratendon and progenitor cells contributes to the cellular healing, not the other ones. So now there is a trend in the literature that people explain you how to use the bursa to augment the rotator cuff tear. And interestingly, if you chop with 50 milligram sections, if you chop with a scissor your bursa subacromial, you might have the highest amount of these cells in the tissue. So maybe there is an indication to augment the repair using bursal sites progenitor cells. What I can do in my daily life, that's now the question for you guys. What you do during your repair and how you can improve the healing rate after rotator cuff repair. Key is indication. As we already heard, maybe acute repairs heals better than delayed repairs in small to medium tears. That's the same thing also for massive tears. They re-rupture quite frequently in the chronic situation, and they have a significant lower re-rupture rate in the acute repairs. We know from different literature the odds ratio is also significantly higher in elderly people with hyperlipidemia, smoking or even nicotine substitutes, obesity, diabetes, hypertension, and alcohol. Regarding the technique, what I can do on a technical point of view, this is a very, very important slide. Although there is a tremendous tremendous increase of published articles over the technique, there is only a slight trend towards a better healing rate and absolutely no influence on the structural and the clinical healing rate. So is it worth that we publish so many articles regarding the technique? I don't know. What is crucial is that where do you put the anchor? It is clear that it's either at the medial border of the cartilage or 2 centimeters below the summit of the greater tuberosity, because there is no difference in tears and non-tears in terms of the bone density and bone quality. It is not clear if it's worth to do an augmentation using a ripstop or a Mason Allen technique, as I do. As you see on the left-hand side, in classic rotator cuff repairs, I do always a Mason Allen. We are doing now a prospective huge study in Switzerland where 1,000 prospective MRIs and patients are included in the prospective study, and we will compare if the augmentation using a Mason Allen is really worth, or it's just a great idea, but it doesn't help at all. What I can do additionally in large and massive tears, 2 studies show a significant better healing rate if you do microfracturing on the greater tuberosity. You know better than I all these studies that came from Paris, which they augmented supraspinatus repairs with iliac crest mesenchymal stem cells. They had tremendous great results after 10 years follow-up in repairs and even in revision repairs. Unfortunately, those studies have not been confirmed so yet by any other studies. There is one study by Kim which showed a significant better structural healing, but no difference in PROMs or range of motions using adipose adult MSCs. A recent meta-analysis shows no clear evidence of using progenitors or MSCs during rotator cuff repair. When you have a good muscle, so a Goutallier 0 to 2, but a short tendon, one option is to augment the tendon, but only if the tendon is in good quality, the muscle is in good quality, and only as an augmentation technique, as you might see on the right-hand side, where we repair on the medial side and just augment it using a scaffold. In the future, electrospun and woven scaffold might be a potential to augment this reconstruction. Recently, a lot of people have said that there is a significant better healing rate if you just decrease the critical shoulder angle by decreasing the acromion index. Our biomechanical data have shown that you just increase the compressive joint forces by decreasing the acromion index, so by cutting on the lateral border the acromion. So in my understanding, you do not have a significant effect on the cuff load if you decrease the lateral acromion. This has been confirmed by Guillaume Villat, the French surgeon, in the United Kingdom lateral shoulder model, where we were able to show that there was not just, again, an increase of the compressive forces. So this might be also one of the reasons why there is some pros and some contrast in terms of the data regarding decreasing the critical shoulder angle. Peri and post-operatively, what you can do during today is don't use non-steroidal anti-inflammatory drugs, because they really decrease the strength and have deleterious effects on the healing rate. Recently, a lot of people popularized some prolonged therapy. Compared to placebo and compared to steroids, there was no clear scientific evidence. So I think this is not something which contributes a lot towards healing rate. Platelet-rich concentrates, which can be classified in these 4 groups, have only a very weak evidence, which might be commercially biased in PPRP and only in massive tears, as Joe has published 2 articles. What is clear that vitamin C before starting the surgery improves early postoperative pain and PONF, but not the healing rate. And vitamin D can improve muscle quality and as well bone quality if you give it postoperatively, and guess how? Over influencing the cellular proliferation and modeling by decreasing activity, remember NF-kappa B. So in summary, what we want to discuss, what we can do in the future, understand the influence of omometry in rotator cuff tears and repairs. Maybe we can modify it, but I think not by decreasing on the lateral acromion. Block specifically the detrimental pathways, including the bad inflammation, using blocking the PARP mechanism. Maybe nanoparticles might be an option in humans by decreasing their activities, because we can block the pathway specifically using these nanoparticles intracellularly. What we have already done in rats, we blocked this pathway not only for tears, as I already mentioned, but also in repairs. And we were able to show better neoenthesis, less scar tissue, and tendency to higher yield load of muscle cross-section subsequent to blocking part 1 in rotator cuff repairs. So as a take-home message, in terms of the origin of the tear, keep in mind an acute tear shows another inflammation than tendinopathies and chronic tears. There is a switch from an acute to a chronic tear with a long-term memory effect, and I think maybe NF-kappa B and part 1 might have an influence on that. We don't know yet which is the role of emmometry versus the biology. In terms of what you can do during your repair, early repair is better than late repair. Decrease acromion index and the CSA had no significant effect on the cuff load. The indication is the key. Using the points that I mentioned here, there is clear evidence in the literature that this increases the healing rate if you decreases the indication for those patients. In terms of the technique, maybe bursal site chopped cells might be the future. Putting the anchors at the medial border and below the 2 centimeters below the summit might have an option. Mason Allen, I don't know if it's really improves the healing rate. Microfracturing may help in large and massive tears. And if you have a good muscle quality but bad tendon quality, augmentation with a patch could be and is a good indication. So far, MSCs either from adipose tissue or iliac crest didn't have a positive effect regarding the healing rates in the systematic reviews. Peri and post-operatively, no non-steroidals, no significant effect of prolotherapy or PRCs, positive effect of vitamin Cs and vitamin Ds. The vision in the future might be understand three-dimensionally the morphology and the biomechanics of rotator cuff tear, potentially understand and interfere the inflammatory degenerative process of these detrimental pathways in the NF-kappa B pathway, in the peritoneal and alpha SMA cells or progenitor cells. And in the future for tendon bone healing, I think specific modification of the healing cells using nanotransfer might be an option. And if you have a short tendon but good muscle quality, nanofiber electrospun on woven scaffolds might be the future. Thank you very much for your attention. Je vous remercie et désolé pour parler en anglais, mais je pense que ça serait plus clair pour vous et bon courage pour la suite. Au revoir.